All right, everyone, it's 10 a.m. here now. We will get started. Welcome to everyone to our third session of Picks for Practice. This is an initiative that is aimed at empowering decision-making for folks who care for the pediatric population. We want to give you the skills to identify surgical emergencies quickly so that the time to intervention is reduced and we can save as many more pediatric lives. The materials that we will share with you are all for educational purposes and is the property of the presenter who has been kind enough to agree to share this PowerPoint with you in the PDF format. It's not for further dissemination, it's for your own educational purposes. Today we have Dr. Brown, who will be joining us. Dr. Brown is a consultant pediatric radiologist at the University of Bristol and the president of the British Society of Pediatric Radiology. She was also the former World Federation of Pediatric Imaging president. Today, she'll be speaking to us about pediatric abdominal x-rays. What are the signs of perforation and identifying other emergencies? We really appreciate feedback. We would love to continue to make this program helpful for everyone. We want to know, what are the things you liked, what are the things you didn't like, so we can make the program better each time. Again, these are for educational purposes. We encourage you to use it for your own learning, but please do not disseminate it beyond educational purposes. These are the partners we have, people who are contributing speakers. We are really grateful to all those who are sharing their expertise with us today. And with that, I will turn it over to Dr. Warrior, Dr. Brown, sorry.
Good morning and good afternoon, wherever you are in the world. And I'm really, really pleased to be here with you and be able to share my knowledge and experience about the pediatric abdominal X-ray. Let me share my screen. Sorry, it went from the beginning. So as I said, I will be talking about the pediatric abdominal X-ray, especially about the perforation and the other emergencies that we can see
as it goes.
Examination.
I want us to not think about.
Okay, let's go. And you know that in the abdominal imaging, in radiology, we have a lot of different modalities to play with. We have the radiography, ultrasound, fluoroscopy, nuclear medicine, CT, and MRI. And radiography, it's probably one of the examination which is the most difficult to interpret and probably one of the most commonly performed. So abdominal radiography, the advantages of the X-ray that it's very widely available, and we can see it in the and we can see and experience it and be able to perform it everywhere in the in our clinics and the hospital. It's inexpensive, but it could be ambiguous. It could be portable, which is very, very good. And also, very often, it gives us the overview of the pathologies and relatively low radiation dose that we have in this X-ray. But there are also many disadvantages that very often is non-specific and insensitive for the abdominal pathology. We really have a wide range of variabilities. It's hard to interpret, even for a trained pediatric radiologist. We sometimes have problems reading the X-ray. We have a limited tissue differentiation, and we have ionizing radiation if you compare it to ultrasound and compare it with the MRI. So common clinical indications where we are doing it in children, in neonates, when we will have the abdominal distension, when we'll be doing when the child presents with the vomiting, when we have a suspicion of the intestinal obstruction, possibility of bowel perforation, placement of the tubes and lines in the intensive care unit. In older children, we will be doing the visualization of the foreign bodies, BP shunt, serious suspicious of the intestinal obstruction or abdominal distension. If we have an ultrasound available in our department, ultrasound will be the first imaging modality for abdominal pain in children, not the X-ray. However, if the ultrasound is not available, then we can do the X-ray. And now I gave you examples of the different X-rays through the childhood images, because we know that the children in our group that are from the newborn, from the 0 day of life, up to teenagers, up to 18 years. So it means the imaging and the visualization of the X-ray will be completely different in this age group. And have a look how the X-ray and abdominal view is changing from the infant to the child and to the teenager. So let's go to the basics. When we look at the abdominal X-ray or any X-ray, we will be looking at the 5 different densities. Gas, which is black on the X-ray, fat, which is dark gray, soft tissue and fluid, which is light gray. Then we will have bone and decalcifications, which do look white, and metal or the foreign bodies, which they are very intensely white. So gas, how the gas will look? If you see the air here looking in the projecting inside the lumen of the small bowel, this will be the appearance of your X-ray. Then you could be that the gas is positioned within the large bowel, and you can see the beautiful visualization of the colon here on the abdominal X-ray. Or you can have a person with a bowel obstruction that you have a gas visible within the distended loops of the small bowel that you can see here in the abdomen, and the loops of the colon visible superior. Then we will have a fat, which is dark gray, and very often we can see here this intraperitoneal fat as a very, very thin line extending along the wall of the abdomen, as you can see here more on the right, and very slim line on the left side. It's very important to remember this because this could mimic the free air within the abdomen, and then we will need to differentiate it normal variant, which is intraperitoneal fat, with a perforation. Then we have a soft tissue and the fluid, which is light gray, and this X-ray shows you with a when the soft tissue organs are positioned within the abdomen and how we can see it on the X-ray. And this will be a shadow of the right kidney, left kidney, spleen, overlying stomach, and the different muscles. Bone with the calcifications, you can see very nicely a ribs on the abdominal X-ray, spine, and the whole bony pelvis. And the metal, which is intensely white, and you can see in this teenager, you have seen the little butterfly, which is her clip in the umbilicus, a little bit another ring within the skin. You have seen the sterilization clips, and you can see buttons on her trousers that unfortunately radiographer have not removed before taking the X-ray. So with the abdominal X-ray, we can do the different projections, and this will be up to our radiographers. But for us doctors looking into the X-ray, it will be important to know the difference because the different pathologies can look at the different on the different projections. So when we have the older children or teenagers, and if we have the adults, then we usually have the erect X-ray. We can have it supine or prone, and this is how the X-ray of abdomen will look. Very often it's very difficult to differentiate in which position the X-ray has been taken if the radiographers are not telling us. The other positions that the patients could have when we are taking the X-ray will be the cubitus position and horizontal, which is cross-table position. And this is very important when we are looking at the X-ray of the newborns, neonates, and little children. The cubitus, it means that the patient is lying on one of the sides and we are doing the X-ray straight through the pelvis. And the abdomen. How do you know it? Because on this X-ray, the spine, you can see it here, is positioned and visible through the mid part of the body, and we can see the spine with the AP view. This is the different X-ray that is often performed in the neonatal intensive care units when the baby is still lying on the back, you can see a position of the spine and the edge of the X-ray, and the spine is visible in the lateral projection. And you can see here the abdomen anteriorly. So the baby is lying flat, and we cut the X-rays through the baby, through the abdomen. And this is what we will be very often seeing in the neonates. You can see the X-ray, which has been taken in the supine position. So baby is lying on the back, lateral decubitus, that baby is lying on the side. And again, baby lies on the back, but with the horizontal view. Very common projections. So when we look at the abdominal X-ray, we need to be really organized and methodical because it's so many different structures to look at the X-ray. So we need to look at the lungs. Very often on the abdominal X-ray, we will see in situations of the baby, sometimes the whole chest or just the bases of the lungs. We can see all of the bones within the abdomen and pelvis. We can look generally of the body shape. We will look the assessment of the solid abdominal organs and the soft tissue. Often in the neonates, we will look on the position of different supporting tubes and lines, and as the catheters and G tube or the ET tube. We will be looking at the calcification, foreign body, or any contrast media that we gave to the children, and also looking at the gas within the abdominal cavity and within the for the free air. And really, during this presentation, I would like to concentrate and look at how the air within the can be presented within on the abdominal X-ray. So, bowel gas, how it can be positioned. We can see the air in the lumen of the bowel, and this will be physiological appearance or secondary to the dilatation of the bowel. We can see the air within the bowel wall, or we can see the air outside the bowel, and this could be in the different organs, or it could be free air in the abdomen. So I would like to divide my whole lecture into these three different categories and three different compartments within the abdomen where the air could be positioned. So let's have a look at the air within the digestive tracts. We know that when the baby is still in the mom's tummy before birth, the baby doesn't breathe the air. So it means that immediately after the birth, baby wouldn't have any air within the stomach or within the abdomen. When the baby will be born and it takes the first breath of air, then it swallows the air and the air will go into the stomach. So very often, if we do the X-ray immediately after birth, we may not be able to see any air within the abdomen, or we will see the small amount of air within the stomach. Within the first hour of life, the air will proceed into to the stomach and the duodenum. By 3 hours, we will have air within the proximal small bowel. 12 hours, we will have air within all the small bowel. And by 24 hours, so the first day of life, we should have the air within the rectum. So if you take the X-ray of the baby who is only 5 or 6 hours old, if you don't see the air in the distal part of the small bowel or within the rectum, don't worry about this, because baby didn't have enough time to swallow enough air for the air to be visible in the area. So careful within the first 24 hours of life of the baby. So when we talk about the abnormal intraluminal air, we need to think if the air is present or is absent. Do we have a dilatation of the bowel, number of dilated loops, location of the dilated loops? Is the abnormality located in the small bowel or in the colon? And do we have the air within the rectum? Because then we will be talking about the different atresias and different congenital abnormalities. So the absent, when we can't see any air on the X-ray, it could be that it's physiological for the patient's age. This baby has been born 1 hour only old, so hasn't got any air. we know that this could be within the physiological limits. Baby may not have the air within the abdomen because it has a high obstruction. So the baby has a atresia of the esophagus, cannot swallow the air, and we don't have any air within the abdomen. Or if the bowel is filled with fluid instead of air, then we won't be able to visualize it with the X-ray. So when we talk about the high obstruction, of course, the highest obstruction will be the esophageal obstruction, but very often this is a clinical diagnosis and we won't be able to see it on the X-ray. With an abdominal X-ray, we can see the abnormality if we have a high obstruction located within the stomach or within the duodenum. We also need to think if the obstruction is a complete obstruction, as you can see it here in these children. It means that there are no air is visible in the more distal part of the bowel, or we will have incomplete obstruction when air is still visible distally within the loops of the small bowel. So let's have a look at the stomach. Atresia of the stomach of the pylorus is very, very rare. But the abnormality, which is much more common, is hypertrophic pyloric stenosis, which is the idiopathic thickening of the pyloric muscle that you can see it here, which is causing the obstruction of the outlets of the stomach. It's very common in slightly older children, infants between 2 and 12 weeks of life, and it's quite common, up to 3 children per 1,000 infants. And boys are more common than the girls, and they present with this projected non-bilious projectile vomiting. When you see the baby with the pyloric stenosis, you will know because the vomiting is so characteristic. So what we are going to do and see on the X-ray, we will see a fluid, we will see a stomach, which is distended, can be filled with air and the fluid, and this is a different shapes of the stomach that you can see it here on the X-rays in the situation of pyloric stenosis. Notice this, that pyloric stenosis, because it's more common in children between 2 and 12 weeks of life, it's a non-complete obstruction. So you will have a dilated stomach, but you will still have visible loops of the small bowel and the air outlining the loops of the small bowel in these babies. So what you do with the children when you have a strong suspicions of the pyloric stenosis, you will do the upper GI contrast study that you can see the baby swallow contrast. You have a contrast within the distended stomach, and you have this pyloric canal, which is elongated with a thickened with the circumferential thickening of the bowel wall. Traditionally, we were doing upper GI contrast study. Now, more and more often, we confirm the diagnosis with the ultrasound, and you can see here this dilated pyloric canal. This is a very, very thin lumen, and on the axial, on the transverse images, you will see a circumferential thickening of the muscle within the pylorus. But again, X-ray will be the first examination that you can think that this could be or suspect pyloric stenosis. Duodenum. In duodenum, we have a different pathologies, which there are quite common. Atresia. We can have a duodenal web annual pancreas, which is causing the suboptimal obstruction. We could have a malrotation and the volvulus. And this is a classical pictures of the duodenal atresia, which has a different types. It could be thickening, which is part of the atresia, is displaced by the fibrous bands without a lumen, or you can have a complete atresia when with the gap between the distal stomach and the small bowel. And this is a classical pictures of the duodenal atresia with a double bubble side, so the dilated stomach, and we have the dilated first and second part of the duodenum, and again, very characteristic appearance. And as you know, atresia, it means complete obstruction. So we don't have any air visible in the more distal part of the small bowel. Classical picture on the X-ray, you don't need to do anything else to prove it. Your clinical history and examination and abnormal X-ray will give you a final diagnosis of the duodenal atresia, and this baby will need to go immediately to theater and have the operation. This is slightly different appearance. Look at these babies. Again, you have here dilated stomach, dilated part of the duodenum, and the same here in the other baby, dilated stomach and dilated part of the duodenum. But what's happening here, you can see the air in the distal part of the small bowel. It means that it is not complete obstruction, and this obstruction will be caused by something else than the duodenal atresia. And in this situation, when we've done the further examination and the patient went to theater, this was caused by duodenal web, and this was caused by annual pancreas. We can't make this differential diagnosis here on the X-ray, but what we need to say that this is incomplete obstruction, and whatever causes for it, the child needs to go to theater because it's an obstruction of passing the fluid and the food at the level of the duodenum. So with the suspicion of one of these two pathology, again, we shouldn't delay the treatment and the patient should have a surgery. Another even more urgent abnormality or finding is malrotation with the volvulus. And if you look at the X-ray, this presentation, once the clinical presentation of the baby, but also appearance on the abdominal X-ray could have very, very similar how it looks to the other pathologies as the annual pancreas or the duodenal web. Again, you have the double bubble sign with the dilated stomach and the duodenum, and you have loops of the small bowel visible distally. But look at the position of the loops of the small bowel. They are all positioned and located on the right side of the spine with no bowel loops visible on the left side. And again, in this chart or in this X-ray, you can see all of the loops of the small bowel visible on the right side of the spine with dilated colon visible on the left. If you see it, it's always suspicion. Always be very careful because this is consistent and very highly suspicious with malrotation. So malrotation is the abnormal position of the small and the large bowel within the abdominal cavity, and majority of this patient will present with the symptoms in the first month of life. If it's only partial malrotation and without volvulus, this could be the incidental finding when we diagnose in the adulthood. Some 1 in 200 will have a asymptomatic malrotation, but if the child will start presenting with the clinical symptoms, especially with the vomiting, then it's the emergency. And why is it the emergency? Because this is what malrotation is what's happened in malrotation. You have all of the loops of the small bowel positioned on the right side of the abdomen and the large bowel positioned on the left. But what does it mean that here the beginning, the root of the mesentery is very, very short, and you have additional congenital abnormality called Latz band, which they are going through the part of the duodenum. It's not only that the Latz band will be causing partial obstruction of the duodenum, but due to the mesentery can go very, very quickly into this rotation and stop the blood supply into the whole small bowel. So this is why it's emergency. If you see the abnormal X-ray and you worry or suspect that it's malrotation, you need to do the upper GI contrast study. You put a contrast, the baby is drinking contrast, and you can see here this characteristic beak in the distal part of the duodenum, suggestive of obstruction. but you need to continue screening and doing fluoroscopy on these babies. And then when the contrast will pass through the beak, you will see here this characteristic corkscrew appearance, because this is how the bowel is rotated along the root of the mesentery, and this is the characteristic picture of malrotation with the volvulus. And why is it important? It's really surgical emergencies. When you have a baby with the bilious vomiting, you need to think about the malrotation and the volvulus, and this baby needs to be sent very quickly by the blue light and the ambulance to the surgical theater. Why? Because if the blood vessels within the mesentery will be closed by this rotation, you have about 4 hours to save the baby. Because if the blood vessels are closed, then there won't be any blood supply going into the small bowel, and within the 4 hours, small bowel will go into the necrosis, and then we will have a baby who won't survive it. So this is one of the very urgent emergencies in the newborn life. And then you can suspect it on the basis of the clinical examination and abnormal X-ray. So let's leave the stomach and the duodenum, and let's into the loops of the bowel. When you look at the loops of the small bowel, you should be looking at the number of the dilated loops, location of the loops, its appearance, and also we need to decide, is the obstruction or abnormality, is it connected with a small bowel or the large bowel? So measuring the bowel loops in children is more difficult than in adults. When you have the abdominal X-ray in adults, you know it's more than 2.5 centimeters jejunum, more than 3.5 centimeters of the alien, and then you have obstruction and abnormal size of the loops of the bowel in the adults. But in children is different. You can't say 2 centimeters, because 2 centimeters dilatation in newborn is different than 2 centimeters dilatation in the teenage. So how to measure if the bowel is dilated? One of the easiest way is to find the L2 vertebral body. So you can see here that on the X-ray, you can see the last rib, which will be connected to the T12 vertebra. You count L1, so first lumbar vertebra, second vertebra, and you look at the distance between the pedicles in this vertebra. So this is normally how the loops of the small bowel should measure. So this is the distance, both in neonates or in teenagers, will be dilated and will be related to the size of the body. So if you have a mild dilatation more than the perpendicular distance, we will think about the mild bowel dilatation. Moderate, we can think about the severe dilatation. And when you talk about the severe dilatation, as you can see here in this baby, you need to decide, is it complete or non-complete obstruction of the bowel? Also, within the bowel dilatation means that there are no peristalsis, because the peristaltic valve is not pushing the fluid and the food that we have inside in intraluminal component. So that again, it will look different on the different projections of the X-ray that I told you before. So on the left side, we have an X-ray that has been taken in the upright position. So this is very common in adults or in older children or in teenagers. And when we have a patient position in the upright, so it's standing on sitting, you will see here this characteristic appearance of the bowel obstruction. It means that the air is positioned in the superior part of the bowel loops, when the fluid is visible in the inferior, and we have this characteristic air fluid level. But it's not so easy in children, because remember, especially smaller children, they don't sit up, they lie flat on the supine position. So if they are in the supine position, the air is visible in the anterior part of the loops of the bowel, closer to the abdominal wall, and the fluid is positioned superiorly. So this is exactly the same pathology as you can see on this X-ray, but this X-ray has been taken in the supine position. So completely different. Be aware of the position. Then When we talked about the bowel obstruction, we can look at the number of the dilated loops of bowel. And if we say that if you see 1 to 3 dilated loops of bowel, then it's suggestive of the higher obstruction. So the obstruction is somewhere in the jejunum, very often secondary to the jejunal atresia or buns. If it's more than 3, we are talking about the lower obstruction. And also the location. Think where the bowel is located and which part of the is obstructed. So you can see here the multiple dilated loops of the small bowel within the abdomen, but you also see the very dilated loops of the small bowel visible here on the left side of the chest. So you can see the right hemidiaphragm here, and the left hemidiaphragm should be positioned here, but it's not visible on the X-ray. It means that the abnormal loop of the bowel migrated during pregnancy through the defect within the diaphragm into the chest. They are dilated, and the pushing dilated loops of bowel pushing the cardiac silhouettes and the whole mediastinum to the right. So this is dilatation due to bowel loops secondary to the diaphragmatic hernia. This is another appearance of the location. There are multiple dilated loops of the bowel that you can see here in the lower part of the abdomen, dilated stomach. But look, they are dilated not because it's some changes within the lumen, but because we have really organomegaly. This is a liver position here on the top, and the spleen that are hugely dilated, that are pushing the loops of the bowel inferiorly into the pelvis and causing its obstruction. And location of the bowel is also important. We just touched it during the previous slides, but this is a slightly older child. Look, is a teenager, but again, look at the size and the position of the loops of the bowel. You can see here that all of the loops of the bowel, of the small bowel, are positioned on the right side of the abdomen. This is a sickle, and the whole large bowel colon is positioned on the left side of the abdomen. So if you see the abnormal position of the loops of the bowel, think about malrotation. And this is when the has been done additional examination on this children. We've gave the oral contrast, and you can see here small bowel study. And again, all of the loops of the jejunum are positioned on the right side of the abdomen. And because the child presented with the acute abdominal pain, and this was in the middle of the night, the adult radiologist did the CT, and you can see here the inversion of the position of the superior mesenteric artery and superior mesenteric vein. I said that this happens in the middle of the night when we didn't have a pediatric radiologist. This is why the CT has been performed. If the X-ray that you can see here was interpreted by someone who is dealing with children, I will spot the difference and abnormal position of the bowel loops. You could avoid doing the CT on this child because the diagnosis is visible on the X-ray. This is why looking at many X-ray and knowing and having the knowledge about the X-ray, it's so important. Another with the abnormal pattern of the air within the lumen of the bowel will be when you see the obstruction within the bowel and dilatation of the more distally. If you see obstruction like this in adults, especially in older patients, you will think that this will be due to the tumor, especially in malignancy. Colonic malignancy are not very common in children, and one of the most common causes will be intussusception. So very often we can see it in children between 6 and 36 months of age, and 90% of these children are less than 2 years old, slightly more common in boys than in girls, and again, patient will present with a non-specific abdominal pain. And classical triad of the abdominal pain, red jelly stools, and the diarrhea it's only present in less than 30% of the patients. So patients still could have non-specific abdominal pain and have malrotation without blood in the stools. And again, looking at the filling defects, like you can see it here, which is the most common place for the intussusception, idiocolic intussusception. You can see here this kind of the pseudomass, pseudo-lesion extending from the through the ileocecal valve into the lumen of the large bowel, causing large bowel dilatation, and similar here, extending into the transverse. And we can also have the extraluminal causes of the bowel dilatation and obstruction, and especially in boys will be a hernia. You know, when the testes descend into the scrotum, we have very often open inguinal ring in the boys, and when it's open with the hernia, the loop of the small bowel can easily migrate there, being stuck there and causing the obstruction. And this is one of the examples here, the loops and the air visible within the inguinal canal, and another baby with the loops of the bowel here extending into the superior part of the scrotum. So always look at all parts of the abdominal X-ray, especially on the edges of the X-ray, and in boys, when you see the obstruction, think about possibility of hernia. Now, how can we make the differential diagnosis between the small and the large bowel? Babies, especially the newborns, have slightly different structure of the bowel to the adults. On the X-ray and in the real life, there won't be any haustra in the neonates. So having the haustra and mucosal patterns, which is characteristic of the large bowel in adults, this is not happening because it doesn't exist in children. But what we can say is that this tension of the large bowel is always more prominent. It could be stretched more than the small bowel. And usually the large bowel will be positioned more dorsally and more laterally than the small bowel. So loops of the small bowel that you can see in the central part of the abdomen and pelvis will be most likely due to the small bowel obstruction and the dilatation. If you see the loops dorsally, or you see it in the lateral parts on the edges of the film, this will be more likely due to colon obstruction. And on the cubitus films or on the horizontal beams films, you will have, when you have a bowel obstruction, large bowel obstruction, you will have a very long fluid levels on these X-rays, because the loops of the small bowel are much longer, when loops of the small bowel will be more packed together and will look like a shorter segment. So this part was about the air and the abnormality within the lumen of the bowel. Let's have a look at a few abnormalities within the abnormal air within a wall of the bowel, because we know that the air shouldn't be present there. So this is a very characteristic pattern of the abnormal air with the children with a necrotizing enterocolitis. Again, big emergency. You need to diagnose on the X-ray, and you need to start treating these children really immediately to avoid the mortality and death of the children. But you need to be very careful, because the feces in the large bowel in the older children could have a very similar appearance. The food in the stomach that's it's partly digested could have a very similar appearance, or the nappy, wet nappy that we have it in the smaller children could have a similar appearance. So always ask the radiographers to do the X-ray without the nappy in the smaller children. But if you see the granular pattern when you don't have a nappies and all over all of the abdomen, you can see it like this here. Is a classical pictures of the pneumatosis coli and the pneumatosis within the bowel wall, and consistent with necrotizing enterocolitis. If we have a bubbly pattern, like you can see it here with the multiple small pockets of air, then it means that the air is positioned within the submucosa. If you have the Kelvinier pattern, you can see here that it's more like a line along the wall of the bowel. It means it's the subserosal air. And with the subserosal air, the infection within the bowel wall is more severe than you only have a small packet. Very often, when we don't treat the children properly with necrotizing enterocolitis, or if the condition deteriorates, then we will have a perforation and we will have a free air that you can see it here along the falciform ligament, or when the infection is progressing, you will have a free air in the portovenous system that you can see here, the branching of the like a black lucent line projecting over the liver. So this is which means that the seriousness of the necrotizing enterocolitis is progressing. And this is another example of the intramural air. And very often we need to tell the patients and we need to tell the surgeons, because if we see only a little bit of the intramural air, as you can see here on this patient, the patient needs to be treated with the antibiotics. But if you see a very extensive changes, as it's here, there will be suggestive of the necrosis of the bowel wall, and the patient will need to have a surgery. So the last part of my presentation, I would like to concentrate on the air outside. So not within the lumen, not within the wall of the bowel, but the free air within the peritoneum, which is consistent with perforation. And again, perforation is the surgical emergency, and we should be treating these children and any patients really quickly taking them to theater. So perforation is very easy or relatively easy to spot on the erect X-ray. Erect X-ray, as I said before, it means that the patient is in the sitting on the standing position. And often we do for suspicion of perforation, we will do the chest X-ray. And you can see very classical pattern of the perforation, what we call the dome side. So it's the free air that is visible under the diaphragm, between the liver and the hemidiaphragm here, between the stomach and the spleen and the hemidiaphragm. And this is how it looks on the X-ray, of the chest X-ray. And this is, if we do the abdominal X-ray, again, you can see the free air under the diaphragm. But this is on the erect X-ray. When we have a supine X-ray, the finding of the signs of perforation are a little bit more difficult. So we can have it increased lucency along the bowel wall, and you can see here the loop of the bowel, and then is a lucent area along the bowel wall, which is suggestive, one of the signs of the perforation. Then we have a triangular pockets of air between the wall of the abdomen and the loops of the bowel, because this part will be now filled instead of the normal tissue will be filled with fluid, or we have the increased lucency over the solid abdominal organs. Look at the difference in the lucency above the liver and above the spleen here. With the spleen, it's very, very white, like between white and the gray, as we know that it's the normal density of the solid abdominal organs, but here is the asymmetry in densities, and it will be a free air over the over the liver. And another characteristic appearance is what we call the Wriggler sign. Wriggler sign, it means that we have a very good visualization of the bowel wall, because we have the air inside the lumen of the bowel and outside the lumen of the bowel. So this is a typical Wriggler sign here. But you need to be really careful here looking at the Wriggler sign, because look at this bowel wall. It's very well visualized, but because one loop of the dilated bowel is superimposed on the X-ray on the other one. So we are not really sure, because this could be due to air within one loop of the bowel and inside the lumen of the other bowel. So this is not sure, not specific, but here it's a typical Wriggler sign, because we don't have any loops of the bowel, but we have the air again along there and over the liver with the increased lucency. Another few examples of the perforation will be this characteristic triangular appearance between the liver and the loops of the bowel, and again a few triangles here, or very typical but very small triangle that you can see here between the abdominal wall and the loops of the bowel, and more examples here with more triangles along the walls of the abdomen, and the big lucency over the liver, and the regular side, good visualization of the loop of the wall of the bowel. Another one of the examples is the free air along the falciform ligament here, that you can see it in the liver in the right upper quadrant, and you can see in this patient, because we have a lot of air over the liver with increased lucency, you can see the falciform ligament as a very dense band of the soft tissue, which is extending near from the porta hepatis, or in this child, because we have only small amount of air, you can see like a line of the lucent line projecting and extending over the one side of the ligament. So both as X-rays suggestive of perforation. And we also have a good visualization of the bowel wall that you can see it here, and a large amount of free air within the peritoneum. That's something what is very specific for children, especially for the smaller children. Just we have a gas free gas, which is positioned, as you can see here, in centrally under the diaphragm and centrally in the upper part or central part of the abdomen, and this is what we call the football side. In adults, the free air will be more positioned diffusely within the abdomen. So if you see the football side, it's very characteristic for smaller children. It could be the number of the features of the perforation on the X-ray will depend on the how much free air is within the abdomen. So you can see here quite a large perforation with a large amount of free air within the abdomen. But in this chart, you can see here only very small amount of air, which is positioned here in the anterior part of the anterior and central part of the diaphragm. But that's very important here in this chart, because look at the other loops of the bowel. You can see here the umbilical clip, so you know that this is a very young child, up to probably week, maybe 2 weeks of life. And you can see very abnormal loops of the bowel here in the abdomen with the small pockets of air within the bowel wall. So we know that the child has necrotizing enterocolitis. And look here in the central part of the abdomen, of the epigastrium, and you do worry that this is increased lucency and perforation. So again, this child will need to go to theater. If you have a suspicion on the supine X-ray that you will see it here, is it just like a fatty tissue or small perforation with small amount of free air? Do the other projection. I know that we worry in children not to give them too much radiation, but it's much better to do another X-ray than to miss perforation, because this is emergency and it's very serious in these little children. So do the horizontal film, and you can see here that the free air has migrated between the anterior abdominal wall and the liver, and you can see it here. Or do the X-ray of the decubitus film when you put the child over the one side, and you see that the free air in this child migrated between within the lateral abdominal wall and the liver here. But again, it's consistent with the perforation. And with the perforation, as I said before, you can have the large amount of air, free air, as you can see it here, or very small amount of air, as you can see here on the other X-ray. Free air under the diaphragm. It's different location of the air between the children and the adults. This is just related to the physiology and how muscles within the diaphragm are developed in adults and in children. So in the children, you will have a position of the free air as I said before, in the central aspect of the epigastrium, under the central aspect of the diaphragm. However, in adults, because the muscles which they are coming from the diaphragm and going into close to the spine, that are much stronger. In this situation, the free air in adults, you will see it under the domes of the diaphragm. So this is a difference between the children and the adults. And in children, you could have a continuous diaphragm site, which is a large amount of air. You can see the increased lucency over the liver, other little pockets of air, and the continuous side lucency under the diaphragm. Or you can have it as a football sign that I showed you before, when the air will be positioned in the central aspect of the abdomen. Remember also that if you see the abnormal X-ray, the position and the position of the loops of the bowel could be caused by something else, which is within the abdominal cavity. And you can see here the increased opacity here on the right side. So we have a slightly increased size of the liver, but you can see here the changes, the distance between the loops of the small bowel and the lateral wall. It's quite big. You have a difference and asymmetry between the right and the left side. If you see appearance like this, it's very often secondary to the free fluid and the ascites within the abdomen. Always remember that the displacement of the bowel loops could be due to a organomegaly, as in these children, or it could be due to malignancy or the lesions arising from any of the solid abdominal organs. So abdominal X-ray, it's very non-specific and it's very difficult to read it correctly, but it's widely available and is affordable. You can do it in every clinic, in every hospital, and is a very good overview examination in both adults and children. And it's a good screening test for most common pathologies and the acute condition. So abdominal emergencies, all or most of the abdominal emergencies that we have in newborns, neonates, and children could be spotted on the X-ray. And I really think that all of the health professionals, everyone who is looking after children, should be able to look at the X-ray and find these emergencies. Yes, pediatric radiologists, we are training with this and we are helping as much as we can. But I think that the abdominal X-ray is now such a common test that we are performed everywhere. It should be read by everyone. And it's in your hands that you can avoid having the delays in treatment of your children if you look properly and diagnose the emergency on the X-rays. So this was a slightly longer than 40 minutes overview of the abdominal X-ray, but I hope that it was helpful and will make you think when you are looking at this examination in your hospitals. Thank you. And do you have any questions?
Thank you so much, Dr. Brown. This was a phenomenal session. We do have some questions. Before I start reading some of them, I just want to also reiterate and encourage the students we have on here to feel free to ask your questions. We really want you guys to learn and start learning at an early stage. The first question we had is, for the purposes of the students, do you always encourage that we have two views, an AP and lateral view, for all abdominal X-rays? Are you concerned about radiation for the X-rays for the neonates who have already had several X-rays, such as for neck?
No, we definitely don't do two views. When we do the X-ray, we only do two views in any patients, both adults and children, when we are looking at the trauma. So when we are looking at the fractures and looking at the skeletal system, then you need to have two views, because you can miss the fracture or dislocation on one view. When you are looking at the chest X-ray or abdominal X-ray, one view is enough. I show you the lateral views and the decubitus views, but this is like a problem solving. So, for example, you have very subtle signs of perforation in newborns or in small children, and you don't know, you are not sure because it's non-specific, then do the second test. But if you have all of the information, one projection is definitely enough. And even now, when we have, I know that we are talking about the abdominal X-ray, but if you have any chest X-ray and you have a chest pathology, we're less and less doing the lateral view, because you can make very often diagnosis on the one view, and we do worry about the radiation.
Thank you, Dr. Brown. Another question is, for the neonates with bilious vomiting, what would you advise to do first, plain X-ray or ultrasound scan?
So if you have the availability to do the ultrasound, I will definitely do the ultrasound, because with the bilious vomiting, you will be looking at the, obviously you have a clinical, you have the clinical diagnosis, so you have a strong suspicions whereas the bilious vomiting is coming, but you need to first think, you need to rule out malrotation and the volvulus. And the ultrasound is brilliant because you put the probe into on the epigastrium, and you will look at the position of the duodenum. Is the third part of the duodenum going into the retroperitoneum or not? And the position of the superior mesenteric artery and superior mesenteric vein. So doing a ultrasound will be my first choice. If I worry about malrotation, also the upper GI contrast study is a very good test. So the X-ray won't be my first test, but if you do the X-ray for the different reasons, you may find the features of malrotation. This is why we explain it in details, not to be missed on the X-rays.
Thank you, Dr. Brown. Third question is, I think you kind of touched on this earlier, is would you also do a lateral view X-ray for cases of pneumoperitoneum where it's not obvious on an AP view?
If it's not obvious, if I worry, yes, I will do it, because as I said, it's much better to do the second X-ray than to miss perforation. However, if I see it, I will finish with one X-ray.
And let me just add this question on here. It's for the students. What will the clinical picture for a patient with pneumoperitoneum look like? Why would we get worried?
Right. So the pneumoperitoneum is signs of perforation, and it's really depends, because in adults or in teenagers, the child can say, I have abdominal pain, it's hurting here, it's hurting here. So the clinical history and the examination can kind of direct you what we are looking for. In smaller children and babies, you don't know it. If you don't have vomiting, you have only distension of the abdomen, you don't know what's going on. So you always worry what it may happen. And this why the X-ray is a good, like an overview examination, what's happening in the children. Perforation is serious because it means that we have a hole somewhere in the viscous. So perforation, for example, in the little babies with a newborns, it could be due to anything which is happening in the bowel, but we always worry about the necrotizing enterocolitis. Necrotizing enterocolitis can be really significant in children, and in newborns can really progress very, very quickly and is serious. If you don't treat these children, if they don't respond very well to antibiotics, the bowel will go into the necrosis. And if you have a bowel necrosis, you need to operate within a few hours, because if not, the child will die. If you operate, you do the excision of the bowel, you do anastomosis, the child has much, much higher ways of surviving. Why we worry about the perforation? Because the perforation could be due to, let's say that the child has atresia in one part of the bowel, and the bowel is in the second part is dilated, and due to increased pressure, it's a little bit hole in the bowel. If you take this child at that time, or the baby, into the theater, you stitch the hole, the baby survives. If you leave the perforation, it means that the fecal material from the bowel, it will go into the peritoneum, and will cause peritonitis. And then it's the much, much higher rate of mortality. These children will be really, really sick. Even if they survive, if you have a peritonitis, especially fecal peritonitis, how is it healing? It's creating all of the inflammatory response inside the peritoneum, and it will heal by fibrosis and causing adhesions. So apart from this, that you have a very sick child with the infection in the abdomen, the healing, it will cause adhesions and secondary problems in the later life in children with multiple or recurrence obstructions. So very, very serious, and especially in the smaller children, that the time is the essence. You take them early to theater, you save them. You delay it, and they will be in the very serious conditions.
Thank you, Dr. Brown. And then we have a kind of two-part question about contrasted studies. The first one is the use of contrast studies has been discouraged. What is your take on this? And then what are the indications or what are the conditions that would warrant use of contrast studies? We usually try to avoid them as much as possible, especially in neonates.
Right, yes and no. We try to avoid them if we can make the diagnosis with the other systems. But if we can't, the contrast study is indicated in children. So for example, if you have esophageal atresia in children, and you have a classical X-ray of the chest X-ray when no air is going into the stomach, you put the NG tube, you can advance the NG tube, you have clinical picture of esophageal atresia, you don't need to do the contrast study because it's not going to give you any more information. You have a differential diagnosis already. You have the diagnosis already. If, for example, you have a double bubble sign on the X-ray, so you know that you have obstruction of the duodenum, again, you don't need to do any more because this is a surgical emergency. You take the baby to theater, you operate, and this is how you treat the child. So you don't need anything more. If, for example, you have a child who is 4 to 6 weeks, it starts vomiting and you don't know. Is it the pyloric stenosis? Is it bad reflux? Is it something in the duodenum? Then I will do the ultrasound because I would like to, because I don't have the diagnosis yet. I would like to help my clinicians what's happening. If you find with the ultrasound pyloric stenosis, you measure the thickness of the muscles. If the thickness of the muscles is between 4 and 6 millimeters and the child is vomiting, but it's not compromising the blood results, so the acid pH level is still contain the normal one, then we can observe the child and the child may grow out of it. However, if the circumference of the muscle is more than 6 millimeters, the child will need to have the surgery. Again, I will start diagnosing pyloric stenosis with the ultrasound, but sometimes you have a really distended stomach full of air and you can't see the pylorus. In this situation, I will bring the patient and do the contrast study because I need diagnosis. And also, it really depends what you have in your clinical settings. If you have someone who is good with the ultrasound, definitely ultrasound. But if you don't have expertise or the machine, it will be upper GI contrast study because it's easier to interpret for a person who is not very good with the ultrasound.
Thank you, Dr. Brown. I have one last question for me, myself. In one of your slides, I think it was one for pyloric stenosis. If you don't mind showing that again, it looked like there was a bullseye sign there, but I always thought that was for intussusception.
Sorry, which one? Pyloric stenosis?
Yes. There was one that had like a bullseye sign from ultrasound, I think.
Sorry, I'm just going there.
Sorry. This one, yeah.
Yeah.
This image on the bottom right.
This one.
Yes.
Yeah.
Is that the bullseye sign for interception, or am I mixing that up?
No. This is just the, sorry, I will just move this one around. No. This is different. So what's happening here? On the ultrasound, always when you do the ultrasound of the bowel, I don't have the slides here, but when you do the ultrasound of the bowel, you can see very clearly 5 different levels of the bowel wall, because you have mucosa, submucosa, muscularis propria, 5 different levels. And for people who are doing ultrasound of the small bowel, you can see all of the levels always. So for example, here you can see the muscularis here in the central part, and this is always the black is the muscles, and this is very dilated and hypertrophy muscles. And when you look at, sorry, let's go back. Where is my stuff? Where you do it here, you can see that this is part of the mucosa. So this is mucosa and submucosa, and this is a thick wall of the blood of the wall of the pyloric, and this is what you can see here. This is mucosa, which is like folded between because the thick wall, it's pushing it inside, and it's folded mucosa. If you have a intussusception looks different because you will need to have another loop of bowel inside with additional 5 different walls. So it's more like a donut site. This is just a single loop of the bowel.
Thank you so much for that. Do we have any more questions? All right. Last call, any more questions? All right. Thank you so much, Dr. Brown, for this session. This was phenomenal. We really appreciate you taking the time to meet with us, and we hope we can have you back whenever your schedule permits.
It was brilliant. So thank you very much for invitation, and I hope it will be useful. And just the right side, when you are looking at the next X-ray, abdominal X-ray, try to look through the different structures and try to identify it, because then when you find X-ray with abnormality, it will be easier for you, and you will get used to looking at the different X-rays. So that's all.
Thank you, man.
Okay, thank you, and have a good day.
All right. Bye-bye, everyone.
Bye.